This is controversial, okay, and my behaviour in this, or my approach to this, the American Diabetes Association, for example, have a lot less developed primary care. So generally speaking, when patients come to their endocrinologist, they tend to be at a bit more advanced stage, and they may not have the same availability to the endocrinologist. So the Americans tend to favour initiation of metformin at diagnosis. I would disagree with that. As I've said to you, in many cases, patients will come into you and they'll tell you all the wrong things they're doing, and they are going to, in many cases, they will undertake a fundamental change of their lifestyle. And you know, if you say to those people, okay, yeah, but here you have to take this tablet as well, and even though metformin is a wonder drug, and the UKPDS have shown it to be an excellent drug, it still can be unpleasant. It can give you a metallic taste in your mouth, it can give you nausea, it can give you diarrhea, and so if you say to somebody, look, you have to take this drug, that may well take the wind out of their sails from the point of view of, I have to take this unpleasant kind of medication, and sure, if I take this drug, sure, I won't have to bother, sure, I'm taking a tablet for it, the doctor's given me a tablet for it. So I tend to avoid medication, at least initially, unless the person has got very high sugars. Now, you know, in that situation, or they present with complications, but generally speaking, the patients that we would see are in the early stages and the sugars are barely elevated. Fasting sugars might be maybe 7, 8, 9 millimoles, and the HbA1c might be maybe 53, 54% millimoles per mole. So you know, you're not dealing with somebody who's, you know, at an advanced stage. You tend to keep a close eye on these people and bring them back in and always warn them. I had one patient about 10 years ago who presented at 60. And somebody we were looking out for because two of her sisters had diabetes, but she presented at 60, initially with just feeling perhaps low-grade symptoms. Then she had more florid symptoms, but within 2 weeks of presenting, she actually developed ketoacidosis. So diabetic ketoacidosis from absolute insulin deficiency can happen at any age, and that's something that you always need to be aware of and just warn people about it, that it may happen, but in the majority of cases it doesn't have. You're absolutely right, metformin would be the first drug really for everybody with normal renal function. So if your creatinine is less than 150, and even at that, you could perhaps, in conjunction with the endocrinologist, and that would be a very, very useful use of the endocrinologist's or the nephrologist's expertise, to actually send them not so much a referral, but an information request, giving them the full details of the patient and what you've done to date, and then perhaps seeking their advice as to, you know, how you might initiate therapy. But in the majority of cases, you're right, metformin low dose, perhaps 500 milligrams BD, and then watching how things go. The next step after that is really anybody's guess. And if you look, as I say, at the latest American Diabetes Association criteria, you can go to sulfonylureas, you can go to gliptins, you can go to DPP-4 inhibitors, etc. But the initial phase, really, the important bit is the diet and exercise and lifestyle, because that's the one that they have to continue with for the rest of their lives.